Hello and welcome to this webinar on the assessment of patients with low back pain. I am Luc Peters, a Master of Science in Osteopathy. I was the principal of one of the largest schools in Europe for 32 years, and I have been an osteopath and a teacher in osteopathy since 1985. I'm the author of the Osteopathic Encyclopedia, of which you can find the URL here. And you can find my curriculum vitae under this URL. What will you learn in this webinar? You will learn to understand pain. You will be able to recognize the type of pain in every patient with low back pain. You will also be able to find the complaint structure, and you will be able to set the correct treatment goals in every patient with low back pain. You will also then be able to implement this knowledge in daily practice, of course, all related to patients with low back pain. Patients with low back pain form the largest group of patients in an osteopathy practice. Something like 51 to 85% of your patients will be patients with low back pain. Low back pain can be lumbar, can be also of pelvic origin or of iliosacral origin or of sacroiliac origin, often in relation with dysfunctions of the pelvic organs, or it can be related to hip dysfunctions. Some therapists say that low back pain is non-specific. Well, low back pain is never non-specific. Every individual patient has his own type of complaint. So there is no such thing as a standardized treatment. Every treatment of patients with low back pain have to be customized to the patient. Also, the pain is very different in many patients, and we have to take that in account as well. Let's first differentiate from where the complaint comes. The complaint can come from the lumbar spine, from the iliosacral joints, from the sacroiliac joints, sometimes related to dysfunctions of the visceral organs, or from the hip region. We try to differentiate these areas by looking and examining for somatic dysfunction. Somatic dysfunction, segmental somatic dysfunction, is typical when we see in a certain segment tissue changes left and right side of the spinal processes. Also, we then find periostal sensibility and, of course, a change in mobility as well as asymmetry of the segment where we find the somatic dysfunction. I first want to repeat something which is very important. Many therapists speak about non-specific low back pain. Well, this is nonsense because every low back pain in every patient is specific. Specific in the structure that causes the pain, also specific in the type of pain. So low back pain is always specific and must be seen related to every individual patient. Let's see which structures can cause the low back pain. Low back pain can come from a single joint or from multiple joints, such as in rheumatoid arthritis. Low back pain can also come from the joint capsule. Joint capsule can be overstretched or in retraction. Low back pain can come from ligaments in overstretched, damaged, or in retraction. Low back pain can come from one or multiple muscles, muscle spasm, shortened muscles, retractions. Low back pain can also find its origin in vessels, like an arterial spasm, cramps. Fascia can also be the cause of low back pain. Low back pain can be caused by the nervous system, of course, the central nervous system, also the peripheric nervous system, and of course also the autonomic nervous system. Low back pain can come from bone, from periost, for example, or low back pain can be of metabolic or systemic origin. There is also, of course, the possibility that the pain is referred pain. To find the structure that causes the low back pain, we have different options and possibilities. We have the case history. So there we have to understand what the patient is telling us. We also have provocative palpation, and therefore we have to be very good in knowing our anatomy. And in this context, we have to be able to palpate all the anatomical structure of the pelvic area and of the lumbar area. We also can work with provocation in compression of joints, for example, or we can test nerves on sensibility, on force, muscle force, of course. We can stretch a nerve. We can also use traction in our evaluation, and we can also use percussion, for example. Understanding the patient is essential. When we do the case history, every patient will have a story to tell and will explain in his or her specific language what the complaint is about. We will have to be able to translate that, let's call it patient language, into a usable medical language. Therefore, we use a lot of keywords, because complaints in the low back are not always coming from a lot of mobility. We also have to consider, for example, hypermobility or compression or inflammation or a metabolic disorder. Let's talk about the specific keywords that we use. Sometimes the patient uses these keywords and then we have to understand them and translate them, but sometimes the patient does not use these specific keywords and then we have to offer them to the patient. So these keywords are, for example, nocturnal. Is the pain nocturnal? Then this is very often a red flag for cancer. Is there progression? That means that, let's say that the pain started a week ago and it's getting worse and worse every day. Also, this is a red flag. Is there pain during weight bearing? Then this could be an indication that there is compression in a certain joint. Was there a trauma? Is the pain position dependent? Is there a start pain, which means that when the patient is sitting for a while and then tries to stand up, is that the origin of the pain? Is there stiffness, for example, in the morning? Is there radiation through the leg, for example, posterior side, ventral side? Are there cramps? Are these cramps eventually local or generalized? Is there a feeling of heaviness in one or both legs? Is there fatigue? Is there a feeling of warmth in the low back or in the legs? Or are there swollen areas? Is there a motor deficiency or is there a sensibility disturbance? We can, for example, also observe a problem with the consciousness of the patient, which then indicates a central nervous problem. The pain can be bilateral or unilateral, which is a huge difference. The pain can be segmental. We can also see eventually generalized symptoms, moistness at the level of the segment, paler. Eventually, we can see swelling, color changes. We can ask whether the pain is position dependent. Is the pain sharp? Is the pain dull? Are there pins and needles, for example, which indicates a compression of a nerve? Is there a time frame that is specific for the pain? And of course, there are keywords that the patient doesn't really use, and then we can offer them to the patient, and the patient can then say, yes, I have this sharp pain or not. Once we know what the pain-causing structure is, we will have to find out what the problem of that pain-causing structure is. There are a few primary types of problem. First of all, there can be damage of the pain-causing structure, such as, for example, in a ligamentary rupture or in a muscle tear, for example. But there can also be near damage, which means, for example, overstretch of a ligament or retraction. There can also be inflammation of the pain-causing structure or infection, or there can be ischemia of the pain-causing structure. Also, knowing the type of pain is important to make up a good treatment strategy. The pain type can be nociceptive or can be neuropathic, can be somatic or visceral, somatogenic or psychogenic, can be referred pain. Also, the intensity of the pain can be important and can be measured in a scale. The threshold of the pain is important, as well as the pain tolerance of the patient. There can be allodynia, and there can also be hyperalgesia, primary or secondary hyperalgesia. There can be acroparesthesia. It can be a central pain syndrome. There can be phantom pain or neuralgia, which is an inflammation of a nerve. There can be arachnoiditis. It can be growing pain. Post-surgical pain. It can concern fibromyalgia or the complex regional pain syndrome, or it can be a breakthrough pain. It can even concern a cancer pain or a polyneuropathy, or it can be a myofascial pain, it can be shingles, it can be a menstruation pain, or it can be neuromas. When we look at the different pain types, we can also consider each time the basic treatment aims. For example, when there is damage to the pain-causing structure, then we can advise rest, eventually surgery, but definitely no manual intervention because there is damage to the pain-causing structure. Another possibility was near damage. Near damage can be caused by overstretch, and then the treatment aim is to take the overstretch away. When there is retraction, we can stretch the pain-causing structure. There can also be inflammation, and when there is inflammation, most of the time this is caused by some kind of compression, and then the treatment aim is to take away that compression. When there is infection of the pain-causing structure, then this is not a case for an osteopath because those patients need antibiotics. There can also be ischemia of the pain-causing structure, and then we must take a vascular aim in our treatment. Let's now look at a few examples. First example, patient 1. There is a patient with low back pain, and he points out the level L5-S1. So that's the pain area. The patient also says that there is radiation along the posterior side of the leg. The patient tells us also that the pain is only there during activity and not in rest. When we do the neurological tests, they are negative, so there is no change in sensibility. When we stretch the nerve, there is no typical pain. There is no loss of muscle force, and the reflexes are normal. The biggest indication here is that the patient says there is no pain in rest, and there is pain only when I move, during activity, let's say. This is a very strong indication that, of course, it's a problem of a nerve, but it's the arterial system of the nerve that is affected. Because during activity, the nerve needs oxygen, needs blood supply. When there is a lack of blood supply, then the patient gets this typical pain. Important in the treatment here will be the area of the thoracolumbar junction, because from those segments we see that the tone of the vascularization of the nerve is provided. Another example, patient 2. The patient has low back pain, and the low back pain is bilateral. It's in the center. It's at the level of L5-S1. It's not specifically on the left. It's not specifically on the right. It's in the center of the body. And there is radiation in both legs. And the radiation is as specific. The patient cannot tell you it's in that direction or in that direction. Important is to notice that the pain is in both legs, so it's bilateral. The feeling is like pins and needles, and this indicates paresthesia, and paresthesia are caused by compression of a nerve. So in this case, we have to look at cauda compression, central cauda compression, or a vertebral canal that is narrowed. Or it can also be a conus medullaris syndrome. Another example, patient 3. So this patient has low back pain, and the low back pain is also in the center of the body. It's bilateral, it's in the center, and the patient tells us that he has more pain at the level of the sacrum, and that there is a band feeling. The pain is there during a longer period of standing or of sitting. Now this indicates that the posterior capsule of the sacroiliac joint is the pain-causing structure, and these ligaments on the posterior side of the sacrum, so between the ilium and the sacrum, these ligaments can be overstretched when the sacrum is in a posterior rotation, and they can also be shortened or in retraction, specifically when the sacrum is in an anterior rotational position. Now, every time when there is a pain and a problem around the sacrum, there has to be paid attention also to the visceral pelvis area, so to the organs of the pelvis. Another example is this patient number 4. This patient has also low back pain, and the low back pain is only on the right side, at the level of L5-S1. The pain is localized on the facet joint L5-S1 on the right side. There is a sharp pain when we compress that facet joint on the right side, and there is also sharp pain when the patient rotates the body to the left, because that also causes a compression of the right facet joint. So in this case, there is no radiation along the legs. All of this indicates a facet joint inflammation. Compression causes pain, and then the aim of the treatment has to be to decompress the facet joint so that the inflammation can heal. Another example is patient 5. This patient has low back pain, unilateral region over the iliac crest and the L5-S1 region. Provocative palpation doesn't give pain in the area. And there is no radiation along the leg. Something like this is probably caused by a higher segment, by a higher level, probably a facet inflammation 1, 2, or 3 levels higher than the complaint area. So that can be in the area of L3, L4, sometimes of L4, L5. The example of patient 6. This patient has low back pain at the level of the gluteus maximus on the right side. The pain is local and very sharp, but only when moving. So the pain is there on contraction of gluteus maximus, and the pain is then very, very sharp. So this is an indication that the problem comes, of course, of the gluteus maximus muscle, and that there is damage, probably rupture in that muscle. Another example of patient 7. Now this patient has low back pain at the level of the gluteus maximus on the right side. The pain is sharp and local, only when the patient moves. The pain is also there very strongly when we do passive internal rotation of that leg. There is also posterior radiation in the leg, but not below the knee. So in the hamstrings region, the nerve tests, length, sensibility, muscle force, reflexes, the nerve tests are negative. Now this type of patients is a typical indication for the piriformis syndrome. So the piriformis muscle causes this complaint, and then we have to check and test whether that piriformis muscle is shortened in spasm or whether that muscle is overstretched. Patient 8. This patient has also low back pain at the level of L5-S1. There is a sharp local pain, and there is radiation posterior of the leg until the dorsal side of the foot and the big toe. So there is loss of muscle force. Foot raise is difficult, so the extensors are problematic. There is a Trendelenburg, which indicates that there is muscle force of gluteus medius. The straight leg rise test, so the stretching of the nerve, is painful under 30 degrees hip flexion. The medial hamstrings reflex is negative, and there is numbness over the top of the foot. So if we have this type of patient, this is rather a medical urgency, and we will have to refer the patient for MRI at least, and probably also for surgery. Now I want to come back to the definition of somatic dysfunction. Somatic dysfunction in a practical sense is a segmental dysfunction in the spine, and it is located there where we see swelling, so there where we see tissue abnormality and connective tissue adhesions. Also, at the level of a somatic dysfunction, there is periostal pain, typically on the periost of the spinal processes. There is, of course, also loss of mobility in the area, and very often we see also asymmetry at the level of that segment where we find the somatic dysfunction. So the somatic dysfunctions can be present in the lumbar area, level DH12, L1, L2, L3, L4, L5, on the sacrum level, but there will not be typical swelling at the level of the iliosacral joints when these iliosacral joints are the cause of the pain. The same with the hip. When the hip causes the problem, then we cannot see swelling at the hip region. A first example of a somatic dysfunction is when we see swelling in the area of the sacrococcygeal joint. We see that more in men than in women. So a localized swelling of the connective tissue. When we see that, and when we additionally find pain, when we palpate the area, the periostal area and the coccyx area, this is another indication for a somatic dysfunction. And when we then test the mobility of the sacrum and the mobility of the coccyx, then we can say that we found the somatic dysfunction of the sacrococcygeal area. This is often related to a very tense pelvic floor, and we see this often in men, and then we can also assume that there is a relation with a dysfunction of the prostate. Another very typical somatic dysfunction is a somatic dysfunction at the level of the sacrum. And we see this very often in women. We then find connective tissue swelling on the sacral area, and when we lift up the connective tissue from the bone, then there is adhesion between that connective tissue and the sacral bone. When we palpate the periost of the sacrum, it is often painful. And when we test the mobility anteriorly and posteriorly of the sacrum, there will be a dysfunction also. Sometimes we even see asymmetry in the position of the pelvis. So with these indications, we are standing in front of a somatic dysfunction of the sacrum. As I told you, very often seen in women, and most of the time related to disorders, dysfunctions of the female pelvic organs. In these examples, we see a somatic dysfunction at the level of L5 and a somatic dysfunction at the level of L4. So when we see the somatic dysfunction at the level of L5, there is swelling around the spinal process of L5. There is pain when we palpate the periost of the spinal process of L5, and there will be a loss of mobility of the joint between L5 and S1. In some cases, there will also be a symmetry of the somatic area. Now, on the right side, you see an image of a somatic dysfunction of L4, meaning swelling, connective tissue swelling at the level of the spinal process of L4, periostal pain typically at the level of the spinal process of L4, can be on the right side, can be on the left side. Then we test the mobility and we will find a loss of mobility at the level of L4 and sometimes also an asymmetry in the position of the segment L4 and the pelvis. I gave some examples of isolated somatic dysfunction, sacral level, L5 level, L4 level, sacrococcygeal level, but of course there can also be combinations. As in this example, when we see connective tissue swelling as well on the sacrococcygeal region, the sacrum region, the L5 region and the L4 region, then we are standing in front of multiple somatic dysfunctions which have to be dealt with separately. So most of the time then I start treating first of all, the lower somatic dysfunction, and I work my way up towards the higher somatic dysfunctions. In this example, we have a patient with low back pain, but we do not see swelling of the connective tissue. So when there is no swelling or no tissue change at the level of the sacrococcygeal area, no swelling or tissue change on the sacral L5 or L4 region, then we can assume that the pain is not caused by the sacrum by L5 or L4, but by the iliosacral joint. So that's a mechanical dysfunction of the iliosacral joint, or maybe also of the hip joint. Because when the problem is caused by the iliosacral or by the hip joint, then we will not see that connective tissue swelling. In osteopathy, it is essential to set up the correct treatment goals. So therefore, we have to find what the complaint structure is. We have to find out what the nature of the pain is, what the problem of the complaint structure is, and then we can treat in different ways. We can treat mechanically. Mechanically, with, for example, as a treatment goal, to take away the compression in a facet joint, for example, or to take away the overstretch of a ligament, as an example. We can also treat in a neurological way. So we have treatment for the central nervous system. We have a treatment for the peripheric nervous system, such as, for example, opening of the foramen intervertebrale to make that foramen larger so that a nerve can pass more freely. And we have also treatment options, most of the time segmental options, to treat through the autonomic nervous system. When the complaint of the patient is an ischemic pain, for example, we have to treat the vascular system. And this can be done by working on the arterial system, on the tone of the arterial system through the segment. We can work on the venous system and drain the venous system. We can work on the lymphatic system. We even have techniques for the craniospinal fluid, for the improvement of the quality of the craniospinal fluid. We also, in some cases, will have to treat more with the metabolic system, such as diet, for example, or lifestyle changes. So we are at the end of this short webinar. I hope you enjoyed it. And if you have more questions, please contact me on info@osteopathybooks.com. Thank you. You are also welcome to visit my website. There are free blogs on osteopathic subjects, and there are also something like 40 books on osteopathic themes with lots of streaming videos, images, and explanation how osteopaths work. Enjoy.